I'm going to call the meeting to order. We will start, as we always do, with calling the roll.
Senator McGarvey. Senator Nemes.
Present in the room.
Senator Schroeder.
Present in district.
Thank you. Senator Storm.
Present, my district.
Thank you. Senator Thomas.
I'm present.
And are you in your district?
No, I'm not in my district.
Thank you. Senator Wise.
Present in the room.
Thank you. Representative Blanton.
Present in the room.
Representative Fleming.
Present remotely.
Thank you. Representative Hatton. Representative Jenkins.
Present in my district.
Thank you. Representative Riley.
Present in the room.
Representative Sharp.
Present in the room.
Okay. Vice Chair Howell. Vice Chair
Present,
Beckler. I'm
Present,
sorry.
my district.
Okay, thank you. Vice Chair Beckler.
Present in the room.
Thank you. Co-Chair Carroll.
Present in the room.
And Co-Chair Nemes.
Present in the room.
Thank you.
I think Senator McGarvey is present as well in his district, but I don't know if we heard him say that.
Okay, I will follow up.
All right, before we get, I guess I'll ask for a motion to approve the minutes from last meeting. Moved by Representative Beckler and seconded by Senator Nemes. All in favor say aye.
Aye.
All opposed, nay. The minutes have been approved. Before we get started, I want to welcome two new staff members that we have. We have Ryan Brown, who is to our left over by the door, and we have Taylor Johnston, who is to our right over by the door. Welcome to the two of you. They are both from graduates from the University of Kentucky Martin School of Public Policy and Administration, and we look forward to working with the two of you. Without further ado, we're going to get into the meat of the meeting. And with us today to testify, we have Chris Hall and Jeremy Skinner, and we're just going to turn the mic over to you guys and listen, and we'll have questions at the end. Thank you.
All right, thank you. Good afternoon. I'm Chris Hall. To my right's Jeremy Skinner. We're analysts for the committee, and we come before you today to present our results of the annual review of the Kentucky Child Fatality and Near Fatality External Review Panel. This panel was created in 2012 by executive order and codified the following year with the passage of House Bill 290, which amended KRS Chapter 620 and charged the panel with conducting comprehensive reviews of child fatalities and near fatalities that were suspected to be the result of abuse or neglect and that had been reported to the Cabinet for Health and Family Services. The panel is charged with publishing an annual report by December 1 that documents its review of cases, its findings based on those reviews, and any recommendations that it has for system and process improvements. The amendment of KRS 620 also required this committee to start annually evaluating the panel. In 2014, which was the first year this committee took up its new charge, staff took a relatively deep dive into looking at topics such as how the panel was organized and how it maintained its autonomy. We evaluated the procedures it used to review cases and how it handled confidential and sensitive information. We checked to ensure that the panel was in compliance with statutory requirements. We also reviewed its budget and staffing. And finally, we compared Kentucky's panel with those of similar entities in other states and national trends. In the subsequent years, staff has provided this committee updates to that 2014 report, to the original 2014 report. This year, staff, it was decided, would take another deep dive, that it was time to take another deep dive into some very different aspects of the panel's operations. These include reviewing the process by which DCBS sends case information to the panel, how the panel analyzes those cases, how the panel drafts its annual reports to meet statutory requirements. We also looked at the effectiveness of having the panel placed within the Justice and Public Safety Cabinet for administrative and staffing purposes. And finally, we compared the panel's operations with best practices established by the National Center for Fatality Review and Prevention. The full scope of the data and the types of analyses staff perform to address these topics can be found on pages 4 and 5 of the report that are in your folders. To remain consistent with government auditing standards, I'd like to note that DCBS was unable to provide staff with all the data we needed to fully address the first objective in time for this report. But committee staff continue to work with cabinet officials to obtain this information. This year's evaluation had 4 major conclusions relating to the panel meeting statutory reporting requirements, the effectiveness of the panel's findings and recommendations as presented in its annual reports, the effectiveness of panel's data collection methods, and issues that have arisen from the panel and Justice Public Safety Cabinet not following the budget process outlined in the 2014 Memorandum of Understanding. The remainder of this presentation will discuss 3 finding areas that allowed staff to arrive at these 4 major conclusions. And the first finding area we wish to discuss with you today is how the panel analyzes data and presents it in its annual reports. The panel statute gives it broad authority to request information about child near fatality and fatality cases from a wide variety of state and local entities. This statute presumes that the panel's work will be based on an analysis of this information they receive. The panel has long recognized the importance of systematically collecting data. In fact, one of the first actions the panel took was to adopt the use of SharePoint, which is simply a secure file sharing program that allowed DCBS and the panel to exchange sensitive case information. The panel also developed a data collection tool that consisted of a list of specific information an analyst would gather from each individual case file, and that represented information the panel had deemed essential for it to have before it systematically reviewed each case. While this provided an initial framework from which to conduct its work, committee staff analysis of the panel's annual reports found that there are improvements that can be made. For example, staff analyzed all of the panel's findings from its 2014 through 2020 reports and found that less than half of their findings are supported by data presented in those reports. Now, it should be noted that committee staff was not privy to specific case information within SharePoint, so we cannot say for certain that these findings were not backed by some type of analysis or informed through some type of analysis. But what we can say is that those supporting analyses are not presented in their annual reports. There's only the finding. Staff also looked at the panel's recommendations for the same period and found that only 25% of their recommendations clearly addressed an issue that had been identified by one or more of the findings. Furthermore, our analysis showed that only 36% of the recommendations listed a particular agency or entity who was to be responsible for making the recommended change or for taking a particular action that was given in the recommendation. Most recommendations left vague who was to be responsible and typically used vague terms such as law enforcement agencies, regulatory authorities, or medical providers. In its most recent annual report, the panel acknowledges that it did need to improve how it makes recommendations, and it continues to work on this. And as the panel moves forward with these efforts, committee staff believe that the National Center for Fatality Review and Prevention may be a valuable resource that the panel should consider looking at. The National Center is a federally funded technical support and data center based out of Michigan, which sets best practices for fatality review panels such as Kentucky. Based on our analysis of the panel's annual reports and the resources that we know exist through the National Center, we make the following recommendations. Recommendation 3.1 is that the panel should reevaluate how it collects and analyzes data it uses to make case determinations, develop its findings, and make recommendation for system and process improvement. The panel should consider working with the National Center to discuss how best to develop recommendations related to its reviews of near fatality cases where abuse and neglect is suspected. The committee staff's second finding area that we want to talk with you today about relates specifically to that data tool the panel uses to cull information from each individual case file. Now, since the data tool is the primary means by which the panel collects case-specific information, it's important that that tool be fully evaluated on a regular basis to ensure that it's still meeting the panel's needs. But this has not happened since the tool's creation in 2014. Staff's analysis of the data tool identified two major weaknesses. First, there seems to be an over-reliance on the use of narratives to collect specific case information. Second, the panel does not have a data dictionary, which is a term we use to describe a document that contains standardized definition for each and every variable that's being collected. Having these standardized definitions for variables avoids inconsistent data collecting and can also help with categorizing case information in a systematic fashion. The panel did recognize some of these shortfalls and recently mentioned that they may try to use a subcommittee structure to review their data collection efforts. Once again, committee staff found the National Center may be a valuable resource for the panel to look into as it moves forward. For example, the National Center offers a comprehensive web-based case reporting system free to states who sign our user agreement, and that might provide Kentucky's panel with some idea about how to reorganize their tool. The National Center's reporting system also includes a 135-page data dictionary that could serve as a model for Kentucky creating one of its own. Based on our analysis of the panel's data tool, we make the following recommendations. Recommendation 3.2 is that the panel should formally review the data tool to ensure it is capturing relevant information needed to make case determinations and to develop findings and actionable recommendations. Recommendation 3.3 is that the panel should consider creating a data dictionary to support their data collection efforts. Recommendation 3.4 is that the panel should consider requesting assistance from the National Center to understand how it developed its data tool and data dictionary. The center may also be able to assist with ideas about different types of information that our panel could capture related to its review of fatality and near fatality cases where abuse and neglect is suspected.
The third and final finding area relates to the panel's funding and budget process. The panel was attached to the Justice Cabinet for staff and administrative purposes. In 2014, the panel and Justice Cabinet both recognized the need for funding and requested $420,000 in annual funding for panel staffing and operations. The $420,000 request was included in the 2014 through 2016 budget of the Commonwealth. However, there was no specific line item or allotment in the budget addressing panel funding. Rather, panel funding was included in the overall appropriation for Justice Administration, which is specifically the funding was included in the Office of the Secretary's budget. In subsequent budget years, the panel funding has been included in the Office of the Secretary's baseline funding. A 2014 Memorandum of Understanding between the panel and the Justice Cabinet outlined the panel's budget and expenditure procedures. However, neither the panel nor the Justice Cabinet have followed the procedures outlined in Section 4 of the MOU, which states that the panel is to provide its budget request to the Cabinet in the fall prior to the budget session, which the Cabinet will then pass on to the Office of the State Budget Director. Other than the MOU, neither party has developed any policies or guidelines to ensure meaningful communications between the panel and the Cabinet as it relates to the panel's budget and expenditures. As a result, the panel's ability to effectively address staff and workload issues through the budget process is diminished. The initial request for panel funding in 2014 was based on a need for sufficient staff for the panel to complete its work related to case reviews and the development of recommendations. However, data from the statewide accounting system EMARS, which is shown on the slide, shows that expenditures attributed to the panel have never approached the $420,000 envisioned by the initial appropriation. Meanwhile, the panel has never been fully staffed as envisioned by the 2014 budget request. Although staffing has fluctuated over the years, it has typically consisted of 2 full-time employees and 1 or more temporary contract analysts. Past panel members and staff have reported difficulty performing case reviews and following up on recommendations due to understaffing. Current panel members and staff have also expressed concerns related to their workload. The panel may consistently be spending less than envisioned because it does not have the opportunity to present its budget needs or to participate in the Cabinet's budget process. Panel staff have reported having limited knowledge of both the budget process and of the panel's available funds. Prior to 2017, the panel received financial updates from the Cabinet. However, it does not appear that the panel has received financial reports or updates from the Cabinet in recent years. While the panel's expenditures are tracked in EMARS, an appropriation allotment was not created for the panel like for some comparably funded programs which are also in the Justice Cabinet. The creation of a separate allotment unit for the panel would provide additional transparency related to the panel's budget requests. Recommendation 3.5 is the panel and the Justice Cabinet should develop processes to ensure that the panel submits a formal budget request to the Cabinet in the fall prior to the budget session, as envisioned by the 2014 MOU. Such a process should involve the development of an appropriate format for the panel to use when preparing the budget and for the Cabinet to use when submitting the budget to OSBD. The process should include steps to ensure that the panel can formally present its personnel and operating requests to OSBD and the legislature as needed. Recommendation 3.6 is the panel and the Justice Cabinet should develop processes for meaningful communication related to the panel's budgetary needs as envisioned by the 2014 MOU. Such processes should include steps by which panel expenditures and staffing requests are considered and approved, and should also include the presentation of financial reports or updates to the panel. And finally, recommendation 3.7 is the panel and the Justice Cabinet should discuss with OSBD the possibility of establishing a separate appropriation allotment as is done for other programs in the Cabinet. This concludes our presentation.
Thank you, gentlemen. We'll go to Representative Blanton first.
Thank you, Mr. Chairman. Gentlemen, thank you for your presentation this afternoon. How are this data reported if there is no definition set forth to what data is supposed to be reported? Because I can see sometimes underreporting, sometimes maybe over-reporting. There has to be a standard set, a definition to go by. So how is those determinations to what gets reported and what doesn't? How is that being handled currently?
First, let me clarify some terms. The data tool and where we're recommending that a data dictionary needs to be created is the panel has a list of variables that it will look at when it pulls a case file. And they have to realize some of these case files are 1,000 pages or more, include videos, pictures, just an amazing array of stuff. The panel doesn't need all that. It needs certain things. So it would say For instance, at the National Center may say date of birth as shown on the birth certificate. Okay, that's like, this is where it comes from. If it's not there, it's something else. Okay, so it's not that they're not being reported, it's keeping consistent. I mean, date of birth is kind of a simple example, but there may be other things they need. For instance, past history with DCBS. There should be a definition that says, well, within how many years? What type of case interaction with DCBS are we looking for? Is it just somebody called, or does does a DCBS agent have to go out? So it's making clarifications like that. Since they don't have a data dictionary, I cannot answer your question of how frequently, let's say this year they recorded interaction with DCBS that involved these things. Next year somebody say, we should include here too that we do this, and so they start including that. Without that consistent definition, agreed upon definition, is where the problem arises and where I can't really give you a full answer. It's not that those information are being recorded, it's that we don't know how consistently those data are being culled from that file. Does that make sense?
Yes, sir. And it sounds to me like right now, we're very inconsistent in what may or may not be being reported, and that can create problems. And it's a very simple solution. We set out definitions so everybody knows what the reporting standard is. And I'm just really surprised we've been this far into this, and we've not corrected this problem already. It's very concerning, because I think we could miss a lot of important data that's needed to help for us to make determinations on how we go forth to protect our children in Kentucky. Thank you, Mr. Chairman.
And we'll ask that question of the panel as well, Representative, when they present. Maybe they can answer the question. Senator Carroll.
Thank you, Mr. Chairman, and appreciate the information that you all presented. It's been a while since I've looked at this. I guess probably since last year. Help me understand. And of all the things you all told us, the thing that concerns me the most is the fact that a lot of the findings, the follow-up to those findings doesn't seem to be always specific, and there's no accountability that anything is being done with those findings. And if that's not happening with every case that they review, then that panel really doesn't have any value. I mean, if they review it and they find things that need to be changed, but yet there's no consistent accountability that those things are changed, then the value of that panel is gone. It's not accomplishing anything. Can you all elaborate a little bit more in that area?
I can a bit. It was not necessarily part of the focus of this year's study, and I forget which year it was that was looked into and mentioned and brought up, and saying, well, there were a couple points I would make. Statutorily, they have no teeth in terms of enforcing these things. And then when if I remember correctly, in those reports that we addressed that, it was they're so busy looking at these cases to meet that statutory mandate. Their answer was that we don't always have time to check up to see if those recommendations were followed on because of staffing. The staff we do have are busy helping us review this year's cases.
And that too, Mr. Chairman, may be something that the panel can respond to. But I think that's something we probably need to look at, because I guess I don't understand the purpose if there isn't accountability at some level upon those recommendations. Maybe not necessarily with the panel, but within the particular cabinet or agency, or at some level. What's to prevent it from happening again if we're not correcting processes or actions that take place during these investigations? That's all I have, Mr. Chairman. Thank you.
Thank you, sir. We are going to, before we move to the panel, I have Representative Fleming on the line with a question.
Thank you, Mr. Chairman. Can you hear me okay?
Yes, sir. Proceed.
Good, thank you. I attended the child welfare Welfare Advisory Committee yesterday, and the DCBS came in and made a presentation and so forth. And I'm starting to get a clearer picture that there's a systematic issue in terms of what Senator Carroll mentioned in terms of accountability and how things are actually set up. And based on what I'm seeing in terms of the reports on the current cases, as well as the past due cases, I think the individual mentioned that they're too busy with these cases, and so there's not. I think there's a concern about a sort of a leadership and understanding of having a more of accountability. Can you comment on I guess the structure of those two entities and how they interrelate? Because I know you mentioned things in your presentation, and I appreciate that. But to me, there is a systematic, structural, organizational issue in terms of what this panel function and what they do versus what's going on in the CBS department.
Just trying to think how to organize my. I would say a couple things. One, looking at the DCBS process is really from the time it gets a call that an allegation of abuse goes beyond the scope of our charge of looking at this panel. There is indeed interaction with DCBS, which is what Objective 1 was about, where we have the data limitation at this time and are still working on getting the data. And so in terms of speaking about data that I can speak to of how that process works, we just don't have those data yet, and but it would be specifically related to how DCBS evaluates cases of fatalities and near fatalities and makes determinations on which cases get forwarded to the panel. That would be within the scope of our charge, of our annual charge under KRS 260. The other parts, I think, would be outside our scope. I'm hearing you and I understand your concerns, but the only aspect I think that's really related to the panel for what you're talking about is what's the process by which these cases are being selected and forwarded to the panel, and we're still waiting on those data. I'm sorry.
All right, do you think the panel? Oh, sorry, I didn't mean to walk over you. I apologize for that. Do you think the panel's role and responsibility should be expanded? Is it too narrow? And of course, that's sort of it's sort of a not tongue in cheek, but it's sort of talking both sides of one's mouth, because you've got some issues going on in terms of the panel getting really involved and doing some oversights, and then you have the CBS is going doing some things. So my question is, do you think? I guess when I'm coming from a statute standpoint, in terms of how the panel is structured, should it be realigned or reorganized or readjusted in order to get, as you said a few minutes ago, more teeth into what they're trying to do and providing some oversight and reporting?
Representative Fleming, I'm going to let our staff think about that question, because I think it's also a question that the panel should ask. I wonder if the answer is the statute's okay, but the panel's not being as robust as what they were designed to be. We'll get into that. I want you to think about that. That's a very important question. But let's go to the panel first, and then we'll come back to both for that answer.
Okay.
We do have a panel that's going to testify. One person is here, so make room for, if you're coming up, Steve. I'm going to turn it over to Dr. Curry. And Dr. Curry, if I would, let me ask you to drive and to introduce the folks that you have with you, if I could do that, and then proceed once you've either introduced them or allowed them to introduce themselves.
Yes, sir. Thank you. My name is Melissa Curry. I'm a child abuse pediatrician with the University of Louisville School of Medicine. And before I jump in, I'm going to ask my colleagues to introduce themselves, and we'll start with Dr. Salt.
So I am Elizabeth Salt. I am a faculty member with the College of Nursing. I'm a nurse researcher, and but I represent the Citizens Foster Care Review Board on this particular panel. So,
thank you, Dr. Salt. And Dr. Kirtley?
So my name is Jamie Pittenger-Kirtley. I'm a pediatrician at the University of Kentucky. I am Prevent Child Abuse Kentucky's representative on the panel.
Thank you. And Mr. Shannon?
I'm Steve Shannon. I'm the Executive Director of CARP, an association of 11 of the 14 mental health centers, and CARP has a representation. I serve that spot on the panel.
Thank you all.
Thank you very much. Thank you, Chairman, and to the committee for giving us the opportunity to respond to the work of the committee staff in their oversight of our panel. We appreciate the opportunity. I do have a PowerPoint that I'm going to spend some time on, but I want to address just a few issues out of the gate. Just as points of clarification. We do actually have a data dictionary. It just happens not to be called that. Within our data tool, on every single data field, there's a question mark. And if you click on the question mark, we have created definitions and guidelines for how that data field is to be completed. That information was developed simultaneously with the data tool when the data tool was originally conceived, and has been continually updated and refined throughout the years that the panel has been in operation. We do continue to use the same data tool in essence, although we have added some data fields over the years so that we can compare longitudinally the data that we've gotten so that we can see what's improving and what's getting worse. And I will mention as well that our data tool has about 240 data fields, which is pretty extensive data to collect from the information that the panel is provided. And our case analysts are the ones, and the panel staff are the ones that pull that data and input it into the data tool in the SharePoint site. The national data tool is 2,500 data fields, which is well beyond the scope of what we would be able to do with a volunteer panel and only 2 case analysts. I wanted to point out that the panel has engaged with the National Center and had the National Center come give us a presentation. It's been, I think, about 4 or 5 years ago, if I remember correctly. I'm sorry, I don't have the specific year. So we have engaged with the National Child Fatality Review resources and have taken their resources into account as we have created the structure and processes of our panel. So I did want to clarify that our reporting has not actually been inconsistent. We do have definitions for each of the data fields. With that said, I will advance through the slides. As was already mentioned, the panel was created in 2012 by executive order and codified in statute in 2014. Our purpose is conducting comprehensive reviews of child fatalities and near fatalities suspected to be the result of abuse or neglect. The panel was designed to reinforce public trust through transparency and oversight of the panel's work. We are designed to be an independent body. We are administratively housed within justice, but are independent thereof. And to further insulate the panel from influence from the administrative branch, there is a memorandum of understanding between the panel and Justice Cabinet defining our autonomous role. Each panel member also signs a non-disclosure agreement. Membership brings together multidisciplinary expertise representing agencies and professions who interface with at-risk families. So as such, we are a panel of experts as opposed to a citizen review process. Members are recommended by respective boards or governing bodies, and several of the nominations are submitted to the Attorney General, who then makes the final appointment. We are unpaid volunteers, and we meet more than is required by statute. Statute requires us to meet quarterly. In 2020, we met 10 times, and in 2021, we have been meeting monthly in order to effectively get through all of the cases that have been provided to us for review. Cases are referred, as has been mentioned, by DCBS, and that includes the cases that involve fatalities or near fatality alleged to be the result of abuse or neglect. So we don't review cases of children who die unexpectedly for whom there was not a CPS report or an allegation of abuse or neglect. So for some types of cases that we review, we're only seeing the tip of the iceberg. DCBS conducts their own investigation to the case and makes their own substantiations independent of the panel. Likewise, the panel makes its findings independent of the findings of CPS. And there are certainly examples of cases where CPS has chosen to unsubstantiate a case and the panel has chosen to make a finding of abuse or neglect. Cases are also referred from the Department of Public Health's local child fatality review teams. So these are local teams with first responders, generally the medical examiner, the coroner, maybe representatives from EMS, DCBS, et cetera, who are reviewing local child deaths in their community and who may have concerns about a specific case that may not have ever been reported to DCBS. So we have a second pathway for cases to come to our attention. So last year, the panel reviewed 182 cases. That was 85 fatalities, 97 near fatal cases. And this year, we're on track to review about 200 cases. And from its inception, we have been given broad latitude to develop our processes and make those align with the needs here in Kentucky. We currently, as has been mentioned, use the SharePoint website for our data tool, which consists of, as I mentioned, about 242 data points. We also determine the type of case or the category, for example, drowning or physical abuse or torture. We determine and code family characteristics as well as other qualifiers and a final determination. So the final determination is whether abuse or neglect was found and what type of abuse was found in the panel's review of the case. So we approach these cases from a systemic lens. That's important to understand. And we do promote accountability while avoiding blame of individuals. We recognize that systemic failures are never the result of intentional or wanton behavior on the part of any individual involved in the investigation. Indeed, system issues are not the responsibility of an individual, but rather failures of the system. We recognize that difficult decisions are made by frontline staff in crisis situations, and we're referring not just to DCBS here, but also law enforcement and other frontline providers. They often have limited information at the time they're making their decisions, and this is all happening in the context of agencies that are beleaguered with staff shortages and limited resources. So it has been mentioned that we are statutorily required to publish an annual report each year consisting of our case reviews, our findings, and our recommendations. Based on what the panel has seen most of in a given year, that is what dictates what data is reported in the annual report. We've been relatively consistent in what data we have chosen to report from the data tool, and it has included those findings that were most pertinent to the largest number of cases. And we'll discuss a few of our recommendations today just to give you some examples. Over the years, we have made several recommendations and advocated for implementation. And as has been mentioned, we don't have the authority to hold any agency or legislative body accountable for whether or not they choose to implement our findings. So we have seen some of our recommendations implemented. We are waiting on others. We are not a lobbying body. We seek partnerships with others to assist in refining and implementing the recommendations. In 2020, the panel made 5 recommendations regarding substance abuse issues affecting families in the Commonwealth. Substance abuse continues to be one of the most prevalent risk factors seen in panel cases, and it's nearly 50% of all cases at 48.9%. Caregivers were determined to be impaired at the time of the fatal or near fatal event in at least 17.5% of all cases. It's important to note, however, that this is likely a gross underestimation because there is not a protocol in place in Kentucky for law enforcement to test caregivers at the time of an unexpected child death, to do toxicology testing. And so consequently, we lack that testing and that information in the vast majority of the investigations that we review. Families struggling with substance abuse often have co-occurring risks that can include mental illness, domestic violence, poverty, and housing instability. And family drug court has been a proven practice that brings together the court system and key supports that are needed by the family, hence the reason for the family drug court recommendation. So this is the 5th consecutive year that the panel has addressed the need for family drug court expansion. And at this time, there's only one jurisdiction in Kentucky that has implemented family drug court, and that has been with private findings. I will interject here that our recommendations are data supported. We would like to have more data-driven recommendations. In order to do that, we would need to have a data analyst, which is something that has been requested, but has not yet been approved for the panel. Other 2020 recommendations include the Plan of Safe Care for Neonatal Abstinence Syndrome and Neonatal Opiate Withdrawal Syndrome. This is a federally mandated plan that each state must have to address the safety and well-being of infants who are prenatally exposed to drugs. And you can see on the slide, these are just the cases that we reviewed where the children had a history of in utero drug exposure. So the in utero drug exposure was not in and of itself the fatal or near fatal event. It simply was a characteristic of the case in the child cases that we reviewed. And this can include both prescribed and illicit drugs. And the majority of children were exposed to more than one more than one substance. The Plan of Safe Care implemented upon release from the birth hospital is supposed to address the safety needs of the child as well as the service needs of the parent or caregiver. A multidisciplinary approach to developing and monitoring the plan is imperative. And while there are strong programs available in some areas of the state, availability statewide of these resources is sorely lacking. The panel recommended that the Department of Behavioral Health, Developmental and Intellectual Disabilities, in conjunction with the Department for Public Health and DCBS, examine existing practices and develop strategies to address deficiencies. This is a need that we have for someone to own this process, the Plan of Safe Care plan, in order for it to be implemented. The panel also recommended that the Child Welfare Oversight and Advisory Committee investigate current practices related to the Plan of Safe Care and provide recommendations to support implementing statewide practices. This was our recommendation number 3. Medication-assisted therapy is an evidence-based approach to achieving sobriety for opioid addiction. MAT involvement was documented in just over 10% of the panel cases reviewed in 2020. Even though those families benefited from that treatment, there are definitely opportunities for improvement on the part of MAT providers. When providing services to clients with young children, providers must be aware of the elevated risk to children in the home. And this risk comes from unintentional ingestion of the medication itself, buprenorphine or Suboxone, buprenorphine containing products. There are also co-sleeping risks when the caregiver who is using medication-assisted therapy co-sleeps with the child, and monitoring for relapse. So providers should integrate prevention messaging into their intervention with these families and make CPS reports when concerns arise to the level of suspected abuse or neglect. So this is an example of a recommendation that specifically says that it's the medication assisted therapy providers that need to implement the recommendation, but the panel doesn't have the authority to make them adopt the recommendation. DCBS and MAT providers need to collaborate in service planning and provision. So regulatory authority should mandate MAT providers to require collaborative services to pregnant women, mothers of infants, and families of young children. That includes prevention messaging and sharing of information with DCBS, and compliance should be tied to Medicaid funding for MAT services. Another recommendation, and we're coming close to the end here, is a drug testing protocol at the time of a fatal or near fatal event. And I already mentioned that we are likely underestimating the number of times that we have a substance impaired caregiver at the time of a fatal or near fatal event, because we do not yet have a statewide law enforcement protocol to do such drug testing at the time of the initial investigation. So the panel has discussed at length with law enforcement representation as well as DCBS representation, and has come to the conclusion that this drug testing needs to be the responsibility of law enforcement, not of DCBS. And so the panel would recommend the Justice and Public Safety Cabinet examine existing practices, existing statute, regulation, and training guidance regarding the provision of drug testing at the time of an unexpected child death or near death. And a report should be developed providing specific protocols for drug testing. The report should address any training and statutory regulatory issues that are needed, and the protocol should be viewed through the lens of potential implicit bias and should be designed to promote consistent and equitable implementation. In other words, this drug testing should not be left at the discretion of the investigators at the time of the investigation, but should rather be a blanket across the board drug testing protocol for all unexpected child deaths. Of note, the panel has developed a subcommittee which is currently developing a best practice approach for law enforcement when investigating child death or near-death scenes. So here is a case example that I'd like to share, that the panel would like to share. This regards a child fatality with substance abuse issues in the home. This was a traumatic asphyxia or suffocation resulting in the death of a 5-month-old infant. Father placed the child in a playpen and left for work after the mother arrived home for the evening. Mother subsequently found the child unresponsive in the playpen. The father had taken the only vehicle and cell phone with him on his way to work. Consequently, mother flagged down a passerby who called 911, and the child was transported to the local emergency department where the child was pronounced deceased. The playpen contained 129 objects such as fingernail polish, soft drink bottles, clothing, books, a plastic bag of clothing, dog feces, etc. DCBS and family preservation providers had noted concerns in the home conditions in earlier visits and described the mother as a hoarder. Due to prior DCBS issues, case plans and court orders required the father to supervise mother's contact. However, father was working a new job at nights and leaving mother to care for the children unsupervised. In this case, father was charged criminally for manslaughter second. From a social history perspective, the home consisted of parents and 4 children. There was poverty, unstable housing, neglect, truancy, and substance abuse issues as chronic issues in the home. This is an example where the index child was born prematurely and was evaluated for neonatal abstinence syndrome due to mother's prescribed Suboxone use. Mother did admit to misusing her Suboxone by injecting it. The infant had required a stay in the neonatal intensive care unit. This child nor a sibling who was also substance exposed, neither had a plan of safe care upon discharge from the hospital despite federal requirements to have such. Mother also reported a history of depression. The family had 14 unsubstantiated CPS reports, 4 screened out referrals, and 6 substantiated referrals beginning in 2009. CPS had ongoing cases opened on 5 different occasions. The family was before the court for the 4th time after the fatality, and the court did not seem to engage in a thorough review and closed the previous case when the mother was 7 months pregnant and receiving medication-assisted therapy. Another recommendation includes that the Kentucky Department for Behavioral Health, Developmental, and Intellectual Disabilities, in partnership with the Department for Public Health, should develop a plan to expand statewide utilization of the psychological autopsy in child suicides. As a society, we tend to treat mental health treatment, especially for children, as though it is optional, addressing mental health treatment as just as important as treating physical health concerns. The panel reviewed 10 suspected suicides from fiscal year 2019, which is only a small subset of the total child suicides in Kentucky. Remember that we are only referred those cases in which there was suspected abuse or neglect. The ages ranged from 7 to 16 years of age, and 3 of the children were aged 10 or younger. According to CaseSpan data, suicide is one of the 10 leading causes of death in children between ages 12 and 17. And a primary tool to help us understand the reasons behind a suicide and to then further our knowledge of effective prevention strategies is the psychological autopsy. This is a process that involves collecting information about the victim through structured interviews of collaterals by trained staff. Kentucky has a small number of individuals that have received the training to become a certified psychological autopsy investigator, and this is an encouraging step, but an infrastructure to begin statewide use of this process does not yet exist. Another case example, this one involving the suicide of a 10-year-old child. This case involves the suicide, mother reported the child had left to go to a friend's house after breakfast, and upon returning home, they were cleaning the house. Mother thought the child was cleaning her room and found her deceased about 45 minutes later. Police described the home as dirty and located a loaded firearm in the rear bedroom of the home. Mother described the child as happy and without any reported issues. However, when the coroner contacted father, he reported quote unquote concerns, but that statement provided no additional explanation in the coroner records. The coroner reporting form was largely incomplete, and it did not appear the DCBS was notified at the time of death as is required by law. This case is noteworthy for what is absent. While the coroner and law enforcement made what appears to be an accurate determination in cause of death, being suicide, the case is lacking any significant information regarding the psychosocial background on this family, and the panel recommended a psychological autopsy be conducted in this case, which would have included collecting all available information on the victim and conducting structured interviews of family members, relatives, and friends. From a partnership perspective, during the last year, the panel has partnered with CaseSpan, which is the Kentucky Safety and Prevention Alignment Network, and developed the Child Home Safety Committee. The committee focuses on research and implementing evidence-based strategies to prevent in-home injuries. The committee received grant funding from the CDC to prevent these types of injuries, and to date, the committee has purchased 501 medication lockboxes, 250 gun cable locks, and 500 trigger locks. These items will be distributed to community providers and will be accompanied with a hard copy of the Prevent Child Abuse Kentucky's Home Safety Checklist. And then for the last slide, I am going to defer to my colleague, Dr. Salt, who will talk about the updates that we are making to the data tool.
Yeah, so thank you for having me and for being allowed to address some of the recommendations, as many of them pertained to the tool, the data tool. And I was involved with the process to try to address some of the recommendations, I think primarily because of my role as a researcher collecting longitudinal data using the software platforms that we have moved to. And then also I've developed scales and looked at the psychometrics of scales in various studies. So what we have done is we did cross-check the current tool with the national tool. As mentioned by Dr. Curry, our current tool has 250 items versus the national tool, which has 2,500. If we estimate, our caseload typically in a month is around 25. If we have 1 minute per item, and then we look at our caseload, we would need at least 5 analysts, which we have 2. So the feasibility of using the national tool is probably a huge limitation to changing tools. Also, from a researcher standpoint and looking at collecting longitudinal data, it would be ill-advised to up and leave your current tool because you wouldn't be able to compare year to year equitably. So there are some definite limitations to foregoing the previously used tool for this other tool. With that being said, we have gone line by line through the current tool. We have moved it to REDCap, which is a software platform which allows each variable to have its own name, and it creates a data dictionary. And so that will allow for data analysis to be more easily implemented, and really, whatever specific variables we want to include in the annual report, we could easily procure with this data tool. With that being said, I think a data dictionary sort of has to be defined. It will create a data dictionary which will define each variable and how that is measured, and the responses, the item stem, and then the responses. But we, as Dr. Curry mentioned, we currently have operational definitions for the different terms that are used in the analysis and that is now being housed in another document separate from the actual tool, so that it's clear that we actually have these two sources of information defining our different variables. As far as I think that those were the primary. We also have received input from the Department of Public Health and epidemiologists. As I said, we've gone line by line through the current instruments and have taken out a lot of the free text, which was also a concern from the panel. So I think that that addresses most of the recommendations made. I will mention too that there was question as to the utility of this panel. I think that that question directly contradicts the recommendations. When you're saying use the national tool and 40 states use this national tool, then clearly all the other 40 states see value in this panel. This panel is diagnostic of underlying problems that we as a community face that we need to address. And as Dr. Curry has mentioned, through our recommendations, we have made efforts to move forward with the problems that the panel finds. So I think that that's really all that I have, but I'm happy to answer any other questions as it relates to the tool or the panel that I have the knowledge about.
I have a question.
Thank you, Dr. Salt.
Dr. Curry?
Yes.
Okay, I have a question. I don't know if it's to you or Dr. Salt or one of the other panelists. Let me lead into it, and that is, I think we've heard that about 10% of what the national organization recommends of the data that we collect, we actually do collect. I think 250 data fields, and I think I heard they recommend 2,500. Are there some of the data fields that we're not collecting important, do you believe?
I'll take that. I think it's important to understand that the purpose of the national tool is different from the purpose for our tool. The national tool is one that 40 plus states report on in order for data to be gathered about different states for national reporting. And that includes things like the family's income, for example, or other pieces of information about the family that we aren't privy to as a panel. I think if we were to try to dig in and get that information, we would actually need our own investigators, because that is often information that neither law enforcement nor CPS collects when they're doing the investigation. So while we do code, for example, the data field of whether poverty existed, and we have a definition that we follow that operationalizes that data field, we do not, for example, collect specific family income information. And that's what the national tool collects. So the national tool is much, much more granular, but it is done for states to collect data to report to the national folks, not for states to use that data to create their own prevention services and recommendations, if that makes sense.
I would think
so.
I'm sorry, go ahead.
I'm sorry, go ahead.
I would think that the reason that the 40 states are reporting it would be not just to see what every other state is doing, but to use that information to further best practices in their own states. And just taking the one piece of information that you identified, you guys certainly don't have that, but the Department of Revenue would, and so I would imagine it would be not very difficult to get. And I'm not pushing back, in any accusatory way. I understand your recommendation or your response says that there's limited authority, and it very well may be that the statute doesn't give you that authority, and we need to give that to you. But my question surrounds, also in your response, you said due to limitations relating to staffing, it was decided that the national tool was beyond Kentucky's panel's ability at the time. That may be so, and I don't know if anyone up here thinks that you need to do all the 2,500. Maybe you do, but 250, 10% might not be capturing the information that would allow the panel to do its job more effectively. And when you couple that with you only have 2 case analysts, I think Dr. Salt said you'd need 5 if you were to do the national recommendations. When you couple that information with the fact that we know that you're not using blame to you and not your call, I would suppose, you're not using the full amount of money that we have been appropriating for your purposes, nor are you allowed to even make the request to, or at least the process doesn't call for you to make a direct request to the General Assembly. It has to go through the cabinet. I think maybe there's some significant room for improvement there. I see, you talked about independence. I see a lot of this in my world as an attorney. The Department of Public Advocacy is someone that's under the Justice Cabinet, but we understand they must be independent. And so the DPA, their commissioner, Damon, Preston comes in front of the General Assembly and makes their particular request. It might be, if you guys, as the experts, think that it would enable you to do your job more effectively, it may be better that you make the particular request to the General Assembly, certainly through the budget of the Justice Cabinet, but similar to what the DPA does, and that we can actually fund and make sure that you get the dollars that are already appropriated, but maybe fund extra workers, case workers, investigators, whatever we want to call them, so you can do the extra things that it seems like, to me anyway, not an expert in this field, might be more beneficial for the Commonwealth of Kentucky and enable you to do your job better. So in other words, is that a way we can help you?
I believe it is. I believe having a line item appropriation would be very helpful to the panel, as well as having those policies and procedures in place for how we can request, funding to be spent. I would defer to, I believe we have someone from the Justice Cabinet and the Budget Office that may be able to speak to that more. But certainly the ability to hire more analysts would be exceedingly helpful to the panel, as well as a data analyst itself. I'll be quiet and let our budgetary person speak up here.
I just want to interject for just 1 second. I do believe that the Cabinet for Health and Family Services does input the child fatalities into some of the national data tool, but that doesn't include our near fatalities. So even if we were to use that data tool, a lot of the cases that we look at wouldn't be included in what the national data pulls in, just to clarify.
Thank you, Doctor.
Thank you.
I don't know if somebody's wanting to, go ahead, Mr. Hamilton.
Yes, sir. Jason Hamilton, Director with the Office of Financial Services here at the Justice Cabinet. And what I've heard today was absolutely, there's actually some truths. There is not a separate line item appropriation, which is very valuable as we talk about funding programs or departments, or even as in the depths of allotments, as was discussed in some of the recommendations as well. This panel, this program is rolled up into the Office of the Secretary. And so along with other programs, there is they compete for those appropriations that are granted to, this authorized from the General Assembly to this cabinet. And so as we have been since I've been here since May of 2020, we'll continue to be supportive and collaborative partner with the panel and continue to listen to their wishes and until that changes.
I appreciate that. It appears that the base funding that we've appropriated to the cabinet is not all for this purpose, is not all getting there. And I know there's a lot of competitive. I used to be until this past year in charge of the Justice Cabinet's budget, so I know there's a lot of worthy programs that are underfunded, no doubt about that. But
hey, Jason, can I ask a question when you get done?
Yes, certainly. We've got two in front of you, but Senator, unless it's directly related to this. But it seems
I'll wait till other people.
Senator, real quickly, Senator. But if it's the General Assembly's priority that this get receive additional funding, then maybe the cabinet secretary shouldn't be the one making that decision. That we should make a line item direct appropriation. I'm going to go to Senator Thomas because I think it's directly related to what I'm saying, and then we're going to go to Chairman Carroll. Senator Thomas. Go ahead, Senator.
Let me unmute myself. Thank you, Chairman Nemes. I just have one question, and this is to all the presenters today. A bit of historical background. Back in 2012, our statewide press, both the Courier-Journal and the Lexington Herald-Leader, were bombarding the public with stories of numerous child fatality deaths across the state. Some really horrific incidents of young children dying. And as a result of those numerous stories, the first Governor Beshear, Steve Beshear, decided to form this child fatality panel to look at and find ways to stop and reduce the number of child fatality deaths. Okay, and since I've been in the legislature, every year when I was on the Health and Welfare Committee, and I think one year we had an interim committee just on this panel. Now we're here before Legislative Investigations Oversight. I've seen annual presentations of where we are, how we're trying to reduce or decrease child fatality deaths, what processes are we using. So my question to you is this: as we approach the 10-year period from the formation of this panel in 2022 will be 10 years, are we making improvements in terms of reducing the number of child fatality deaths? Because you guys have presented some very sobering stories this afternoon. I've just got to tell you, are we just holding our own, or are we getting worse? Please answer that question for me.
I'll attempt to give an answer, and then it looks like Dr. Salt has some comments as well, perhaps. I don't think we know where we would be in Kentucky if this panel hadn't been in existence. Are we seeing a huge drop in the numbers? No, absolutely not. We're not seeing a huge drop in the numbers. And we're seeing worse and worse cases. What we don't know is how much worse might that have been if we didn't have the panel making recommendations and, working with DCBS about, areas that need to be improved. And I think that to some degree that's unknowable. So I absolutely appreciate the spirit of the question and have the same curiosity about, what impact we're having. But what we don't know is where our numbers would be if the panel wasn't in existence. Dr. Salt, did you have something you were going to say?
Well, I think that the point is that you can never start improvement if you don't understand the problem. So if you don't have someone that can define the issues, which is what this panel is charged with doing, then how could you ever make any attempt at change? So if we do away with this panel, we will know nothing, and problems will arise, and we won't even know that they are coming to fruition. So that, I mean, I think that should answer your question.
Thank you, Doctor. Senator Carroll.
Thank you, Mr. Chairman, and appreciate all the information. And, with this is obviously a very esteemed panel that has been set in place, and a lot of credibility, and not to maximize the recommendations, not to ensure that those recommendations are followed up on in a timely manner, I think is a travesty. And I want to make clear that none of my comments are placing any blame on DCBS or law enforcement by any means. I think we can all agree that our system in DCBS is inadequate simply because they don't have the staff. And that is an issue, an entire issue unto itself. And we are failing in that area. Talked to Senator Higdon yesterday, who had met with some social workers from his district, talking about the shortages they have. That's something that's got to be addressed, and that I think that in itself is a significant part of this that we have to look at. So, when my comments are going to be related to processes and systems that can improve what we do in the investigative area, whether that be law enforcement or DCBS or our court system. So it's a little troubling that, the report's put out, and Dr. Curry, can you kind of answer for me of the recommendations that you made? What is the attitude, or what is the expectation of the panel on what's going to happen with this? Has it gotten to the point that a lot of times it's just a formality to put these out and you don't have any hopes that anything's going to change? Because if that is the case, we need to establish a direct link from your recommendations to someone who is accountable to ensure that those recommendations at a very minimum are researched, and maybe a direct link to the legislature also. I would be happy to carry a bill that required drug testing on fatalities or near fatalities. We do that in law enforcement when there are vehicular homicides, manslaughter, deaths related in collisions. I don't know that there would be any constitutional issues with this. That would be really my only concern, but I don't think setting that up within statute would be all that difficult. Just having to understand the constitutional implications of that would be my only concern. But my point is, if there are direct contacts established with each recommendation and then some accountability, then I would think, if I was a member of that panel, I would feel a lot better that my time was being well spent. I can't imagine sitting on a panel with the expertise that you all have and not knowing if anybody is paying any attention to your recommendations. And I've said a lot, so I ask that you please comment. And what can we do to make you all more effective? Obviously, you give me an amount that you all need to implement your programs like the legislature intended you to. If you can put that in writing, I'll be happy to try to get added to the budget specifically for your program. And I know there are many members sitting in here right now that would be happy to do that also. So with that being said, and then, should we put some requirements that each year for your recommendations that those recommendations go to a specific cabinet, a specific agency, and give them 6 months to finalize whatever efforts they're going to make, and then report to this committee. So tell me what we can do to make your process more effective. We can't establish this and halfway invest in it and then just send a report out every year and something probably not going to happen. Why would we waste our time? Why would we waste your time if that's the best we can do?
Thank you, Senator. I appreciate those comments. And yes, I think absolutely anything that can be done to make our recommendations more to improve the accountability on the different agencies as far as our recommendations are concerned would be helpful. To directly answer your question, no, I don't think the panel members are resigned to our recommendations being, relegated to the back page of a report. I do think that we are frustrated, many of us, that more hasn't happened. And I think that we would absolutely appreciate any additional support on the part of the legislature to help, hold different agencies accountable. I will say, when you ask what else can be done to help the panel work better, we certainly can get you that in writing as far as a dollar amount. But we do have 2 appointed legislative committee members who we acknowledge are extremely busy, as probably most of the members of the panel are, but we have not had participation from the legislative members to a large degree. And I think that would be very helpful to help the panel understand what's feasible from a policy standpoint and what isn't. And I will stop talking and let my colleagues, I don't know if Mr. Shannon has anything he'd like to add.
Yeah, again, Steve Shannon with the Mental Health Centers. I think it's a great question, Co-Chair Carroll. What happens with the work that we do? Okay. And I've been on here 5 or 6 years, and I think, and no one's getting frustrated. The work is invaluable. I attend a lot of meetings. My wife knows when I've attended this meeting, because when I come home, and a lot of you know me as the pension guy. Pension's a diversion from this. This is really tough work. But I do raise the question, and I think, Dr. Curry, we need to get teeth. What can we do when we make a recommendation? Who's going to follow that? And, I will tell you, and I've said this at meetings, the frontline DCBS worker, it is the worst job in state government. My apologies to state police, Representative Blanton, and corrections. These folks go into homes, so we don't want to be critical. It's really hard, though, when we make recommendations. What can we do? And it's not critical of DCBS. They have just overwhelmed amount of work. But how can we move forward? We talked about having an epidemiologist to help us with data analysis. This is something we all do in addition to our job, so it's hard to fit that time. How do we get to a place where those recommendations, is it this committee? Do we come with recommendations to this committee annually? What does it need to look like? What can we do? Other members have told me that we make recommendations. We think it's important. What happens? Who does it? And I'm the guy who does governmental affairs on the group primarily. And I don't know if the expectation is for me to do this, right? But I think it is time. I said this at a meeting last week. I'm reading a book on the Monument Men, and the leader said, I have about 20 years left to work. That's enough time to play, not to work. I don't got 20 years. This is one of those things we need to figure out. The stories are horrendous, and we need to get systems in place that recommendations move forward. I sit back and listen to the likes of Dr. Curry, Dr. Salt, Dr. Kirtley. They know more about this stuff than I can ever imagine. We have people who really understand what needs to happen. I think we just need to find a place to get that voice heard. And no one is critical. DCBS is there. They're participating. We don't want to be critical of frontline workers. But where can we go? To whom can we give these recommendations so they're implemented? That's the real question.
If I might, Mr. Chairman, and Steve, I think the answer might be very simple. I think the co-chair is absolutely correct in that this panel does need to be independent like the public defenders are. And when you all have your meetings and you have a recommendation, iron it out, come directly to a legislator. And that happens all the time. And this is a subject that I don't know that there's anything else more important that we do in Frankfort. And especially this day and time with the challenges that our families are facing, that our kids are facing, it's critical that these systems are as efficient and as sound as they can be. And I've been there. I've worked these cases. I've made mistakes in these cases. So knowing that there is a body that's reviewing, if I had a case that was a fatality and I failed to do something, or the I didn't follow. I would want to know that. So it's invaluable as these agencies move forward, as is the part about the social workers and taking care of those
Yesterday's testimony
issues.
was this committee, was this panel
Yes.
at the Child Welfare Oversight. It was this issue. I mean, it could have been this report, in my opinion.
And I think we do have to work on that. But for the recommendations themselves, any draft legislation that you all could come up with, obviously you can come to us. Yeah. We can connect you all with bill drafters to look at constitutional things. And I, for one, am anything that this panel does, based on my background, is going to be a priority on my legislative agenda. That. And Senator Wise, with his background, Representative Blanton, several others here. So it can't just be, I think the panel has to be aggressive and has to go directly to the source, to the people who can make these things happen.
We haven't been that. And I'll own as the guy who probably should have been pushing that agenda. Okay. But we've never had that mechanism, truthfully, to go outside. We have a great relation with the Justice Cabinet. We appreciate that relationship. We don't want to disrupt that. We work very closely with the Cabinet, the Health and Family Service, DCBS, but we've never had that, is there a way to create us as a standalone? And I think at one point people talked about that, but we just never, we're 30, 40 people that get together once a month, now on Zoom, and talk about bad stuff.
Steve, you do have that contract that creates a little bit of independence from the cabinet. I'll talk with Chairman Petrie, and I'm sure Chairman Carroll will talk with Chairman McDaniel to get that line item in the particular.
Yeah, I don't want to get crossways with the cabinet.
No, you're not at all.
Yeah, and nor do we. Yeah, and it's and I think they would agree that this is a priority. Knowing Secretary Harvey, this will be a priority for him, and so I don't think it's about that at all. But if a system like this, if a panel of this magnitude is going to be established where some very prominent experts are giving of their time, we as a legislature have got to make sure we're giving them every tool to succeed. Why do it if we're not going to do that?
We appreciate that message.
So the processes are in place, and I think it's just more direct contact. I'm ready right now to the drug testing. I'll file that next session. I'd be more than happy to.
That'd be exciting because we've talked about that at every meeting for the 5 years I've attended.
I'd like to know where the pushback is on that because,
I think it's really when you talked about authority. I'm not sure we had a place to do that, right? So this is a great opportunity for us. Okay. Raise real issues that we've talked about a lot. So I think so I don't know if there's push because we've never had it outside of our meeting, this conversation.
Okay. And Mr. Chairman, I could go on, but I will stop. But just know that the help is there and personal contacts. I would love to attend one of these meetings and just hear what goes on and
Tuesday afternoon.
See what I can do
Zoom.
to help. Thank you, Mr. Chairman.
Thank you, Mr. Chairman. We've treated this issue differently. We have to do an annual report on this committee. We revamped this committee a little bit. It's a 10-year anniversary of the panel. Maybe it's time to put some teeth and give it a bite. Representative Blanton.
Thank you, Mr. Chairman. Thank you to the presenters. First, if I may, a quick comment, then I have a question for Dr. Carey. Dr. Carey was explaining one of the cases dealing with a child that died in a home that was 5 months old. And when she began to describe the way that home was, the way that child was living in that residence, I heard a lot of gasps from members of the committee and members in the audience. But you know what? It's a shock to you all, but to our DCBS workers, to our law enforcement people, it's not a shock. It's a shock to you because you heard it. Go see it. We have ride-arounds all the time with law enforcement. Go ride around with a social worker. Those people have my utmost admiration. I once went into a home with social workers, and they was always talking about taking children into emergency custody. We had the ability as law enforcement to take them into protective custody without any orders. And I've been into those homes, and I've taken children at my discretion into protective custody because of the conditions that Dr. Curry described. And you think it's bad. You have no idea till you see it and you smell it and you're there and you see what these children are living through. We've got to find a way, and I'm an outsider who's very blunt, okay, that came into the General Assembly, that's worked in state government my whole life. And this panel has a great cause and a great purpose. But it almost seems to me it's been a panel like many things that state government is notorious for doing. It sounds good, let's put it together. And then you've got dedicated professionals that's trying to really do something to make a difference, but yet we're not putting our money where our mouth is and making sure they can actually make a difference. And I think we got to do that with this panel, with our DCPS, with our law enforcement, all of them involved. It's time we step up and we get serious about children's lives and everything that we do here. But so I'm supportive of giving this panel every tool it needs to be effective, to do the job that the people I believe that's on this panel would like to be able to do. And so you have my full support of that. With that comment, I do have a question, Dr. Curry, for you, and clarify, correct me if I'm wrong here, but if I remember in my notes here, in 2020, you had about 182 of these children. You're anticipating around 200 for 2021. If those numbers, if my recollection is correct on those, do you happen to have the numbers for 2018 and 2019?
I don't have them at the tip of my fingers, but I can absolutely get those to you.
I would appreciate it, and I asked that question because during everything that's went on in our world over the last 18 months or so, we've seen an uptick in crime. We've seen an uptick in domestic violence. I want to see the numbers go back years preceding into this to see if we've also had an uptick in the number of fatalities or near fatalities of our children, with everything that's been going on over the past 18 months with being more confined at home with parents that are abusers because of being sent home from work or school shutdowns and those type things. Have we seen an uptick also in this realm as well? So, Dr. Curry, if you could please provide those to the committee, I would appreciate it. Thank you.
Yes, absolutely. And we have seen an uptick. I just will need to get you the exact number, then we'll do so.
Representative Bland, if you'll look on page 11 of the report, table 2.2, that lists the number of fatalities the panel reviewed and the number of near fatalities they've reviewed from 2016 through 2020 and the expected numbers for 2021.
I think too that the concern is that there was a significant decrease in reporting initially after COVID, and probably because only 16% of cases are reported by people that are not professionally linked. So, teachers, healthcare workers, law enforcement. So all of the systems to report child abuse were disenabled because of COVID. So potentially the intensity or the severity of the cases might have increased because people weren't responsive to the situations that were occurring. So I think that that question remains. We've done a lot to look at comparing suicide, pediatric suicide before and after COVID, child abuse before and after COVID, and but looking at healthcare encounters. So it'll be interesting to see the evolution of this specific data.
Yeah. And anecdotally, the mental health center saw a lot of kids at schools, and obviously did not see kids at school.
So with respect to the numbers, I'm from Louisville, best place on earth to live. I'm sorry to my friends that don't live in Louisville, but you should. We do have some problems, obviously. We've got a lot of really good things going on. One of the problems is, as of September 23rd, we've had 27 students in JCPS who've been shot and killed. Another 91 have been shot and survived. Do we look at those at all? Does the panel look into that? Those over 100 kids who've been shot, 27 of whom have been shot and killed. Is that ever something we look at it? There obviously probably is some abuse and neglect in those situations that might have led to certain situations? I don't know. Do we ever look at that?
No, sir. Those cases have not come to the panel because there has not been a report made to DCBS in those cases. Largely, I think the causes of those cases get attributed to external factors rather than internal family factors. I do think it would be very interesting for us to see those cases and dig into them. But as the panel is structured currently and the way that those cases come to us, there is no mechanism for us to review those cases. Excellent question, though.
Thank you, Senator Carroll, and then Representative Fleming.
Just quickly, Dr. Curry, is the current system of selection on what you all review, is that the best way to do it? And I'm not being critical of DCBS, but having an agency choose what's reviewed when it's often their work that's being reviewed, is that the best, most credible way to do that?
I think that's a great question. Overall, I think yes. I think it works well because they send us all of the alleged fatality, near fatality cases, regardless of whether they substantiate the finding. So to my knowledge, we're not missing cases. Now, there are certain types of cases where we're only seeing a small fraction of the overall number of that type of cases. Sleep-related deaths would be an example of that. You know, one could make the argument that all sleep-related deaths, if there is unsafe sleep involved, should be an allegation of neglect, but that's not how DCBS assesses those cases. So consequently, if no one ever calls or notifies DCBS or makes a report about a concern for neglect or abuse in those sleep-related deaths, they will never come to the panel for review. Now, there is another review panel through public health that looks at those deaths, and they will at times hand select cases from their reviews and send them to us through public health, and so we will get them that way. But I defer to my colleagues to speak up if they disagree, but I think overall it seems to work pretty well.
I would agree. And I was texted by someone. I should have said Jefferson and Odom are the best place to live. Some people I represent in Odom want to make sure that the Jefferson area, the little area.
That just cost you some votes.
That's right. Representative Fleming.
Thank you, Mr. Chairman. I guess it seems to me, just listen to the discussions and so forth, that the General Assembly sort of has failed this panel. Because I think there's a true intent to get it going and so forth, but we didn't give you all the tools to operate, because I can tell that there's the strong mind and a great heart behind the panelists in going through and using what y'all have in order to do the best you can. But it seems like when you make a recommendation, it goes in the abyss. So I just want to, first of all, just sort of support what the other comments have been made in terms of we are going to be committed, at least I'm going to be committed to help y'all out so y'all can do your job, because I think y'all are being volunteered and going through this process. My hats off to you, going through the stories and seeing those situations. I know it's difficult. I run a mental health nonprofit, faith-sensitive organization, and I see a lot of the ramifications of what y'all go through. So I understand wholeheartedly what's going on, and if there's anything we can do, I'll throw it out to Senator Carroll. I'll be more than happy to carry his bill on the House side, but I think Representative Blanton's got a stronger law enforcement background and more credibility than I do when it comes to that. But I think we definitely ought to look at a line item budget. I want to just reiterate some of the things that has been said, but I do have just two questions. Dr. Curry, once again, I appreciate you and your panelists for all what y'all do. And on a side note, I do like your wall back there. It's nice and colorful, so it keeps you nice and bright and shiny. You mentioned about a psychological autopsy. Could you expand on that a little more in terms of what goes, what goes into it, but what happens to that? How's that utilized, if at all?
So a psychological autopsy is performed by someone who, or at least is led by someone who has the training to conduct this kind of investigation. And it involves talking to contacts of the deceased child to try to get a better understanding of were there concerns? Was there a mental health need that wasn't addressed? Or if it was addressed, was it inadequately addressed? What other factors were going on in the home? Was this child a victim of abuse or neglect? And was that not reported or not recognized? And did that contribute to the suicide? And then the findings of the autopsy are shared with community organizations that do prevention work. So, for example, the school system, and we have suicide prevention programs that are present in the state who go to the schools and give presentations. If they better understood the dynamics of what causes a 10-year-old to kill herself, that may then be built into the presentations to the school. So the more we understand about why the kids are making these choices and where we are missing our opportunities to prevent it from happening, the better the prevention programs will be. And if any of the other panelists have anything to add, this is not my best area of expertise, I will say. I've learned about the psychological autopsy from my time on the panel.
I just think the more we know and the more we know how to intervene and reach these children and to address topics that they need, the better it's going to be for them. By trade, I'm a hospitalist. And so the amount of suicidal ideations and suicidal attempts, we're not even talking about completion, that we see in the hospital, especially through right now, has been staggering. So it's definitely kind of something we need to focus on. And the more we know, the better it will be for everybody.
Well, I concur with that statement. Do you know the information that you pass along? Do you know can you give me an example of where it might have hit? We've had some pay dirt where it's actually rubber hit the road in terms of them or our organization actually implementing what they've come up with that report.
I don't know that we have seen a completed psychological autopsy at the panel. I think that we have made those recommendations and we've talked about the importance of it, but I don't think that we have, determined a way to implement those or to have them implemented. Mr. Shannon, you looked like you were going to say something.
I think it is, I spent a lot of time in the mental health world. We don't have a lot of people who've been trained in this. I think this is a new piece to me to look at. And I think it's an opportunity. And once it becomes something that's viable and is needed, you would end up having people trained on how to move forward and conduct these in a way that is consistent across the individuals and you get the data we need to have. I think it's just not something that many people have really thought about. Maybe that's unfortunate, but I think that's part of the answer, Representative Fleming, is that there's just, I don't know how many people in Kentucky are really certified to do this, right? I mean, I've never seen that number. I don't know if there's any training. I know, I get a lot of training stuff, but I've never seen anyone doing a workshop on how to do a psychological autopsy. So I think it is a missed opportunity, for us to gather information that can help, if an attempt, help other kids down the road, identify things early. And that's really what everybody wants. We want to equip teachers, cafeteria workers, bus drivers.
That's going through that autopsy, psychological autopsy, that's raw, powerful information that from my side, I'm drooling to get that information, because that taking a holistic approach to find out a solution, that's the way to go. So whatever you do to help to do that. One last question, Mr. Chairman, it should be a real quick one. Dr. Kerr, you mentioned about a data analyst in your recommendation and so forth. Have you put a number to that?
I would defer to our staff person who I think is on the call. Alicia, do we have a number for how much the data analyst would cost?
We do not have a hard number yet, but I will say we are currently working with 2 epidemiologists that have been provided to us through the Department for Public Health. So we're currently utilizing them, but we are talking with the budget staff, with the cabinet, to develop that.
Good. Well, we look forward to, at least on the A&R committee, to looking those numbers up, put y'all in a line item, and then try to get y'all to the level where y'all need to be. So thank you very much, Mr. Chairman, and thank y'all.
Last session, there was legislation, that created mental health first aid. There's now a teen mental health first aid. Again, it doesn't create clinicians, it creates identifiers. I think that's another piece that we could talk about and add to the mix.
Representative Beckler.
Thank you, Mr. Chairman. Question on suicide among teenagers and young people. I doubt that the young person understands what suicide really is. Not, an adult in general knows that suicide means death, understands what death is. But I really question whether or not a young person does. With that in mind, have there ever been any studies that show what kind of information should be given to a young person that can address suicide? It just seems, and I would suppose that with all the esteemed members of this panel, that an answer can be given. But it just seems to me that just telling young people that suicide is bad, it's going to be death, I can't believe that they understand it. So has anything ever been done nationwide within Kentucky to kind of address how to approach a child?
There's suicide hotlines. That's one piece. There's groups that focus on teen suicide, and they do education, they go to schools, they do prevention stuff, okay? The real challenge is what has happened. It happened maybe in Oldham County several years ago, Chairman Nemes. There was a suicide, and there was 2 or 3 that followed afterwards. So I think part of what you said is, do they really get it? But there's groups that do this. Also, July of 2022, we got to have a 988 number in Kentucky. That is a suicide hotline that people can call and be connected to a clinician. It's the equivalent of 911. So there's a lot of conversations about what we can do. Prevention programs at mental health centers talk about this as well, to schools as well. The question is, and this gets me in trouble with my employers, essentially, do we always get the right people? Do the kids who need to hear it, hear it? That I can't tell you. But there's people doing this work throughout the state today about,
I just want to add, there is data about what most effective messages are and what ineffective messages are. One of the things that we know, for example, is that we have far more copycat suicides following a suicide if the media reports the method of suicide. We're trying to, educate the media not to report how the suicide was effected, that we intentionally left that out of the case presentation today for that reason. So, the other thing is peers and helping peers recognize the signs of suicide and empowering peers to seek help for children who are in pain. And, I'm going to go out on a limb and say I actually think the children do understand that this is death. And I think that we sometimes don't wrap our heads around the amount of pain that some of our children are carrying with them, whether it is because of their family background or an untreated or undiagnosed mental illness or a combination of the two, history of abuse or neglect, et cetera. So yes, it is. The prevention programs are evidence informed. And that research is ongoing.
Thank you. Thank you, Mr. Chairman.
Representative Blanton.
Thank you, Mr. Chairman. More of just a comment. While we've had the questions going on, I've sat here and did some math. And I'm just wondering why the media, while we've reported on a lot of deaths over the past year, our child fatality rate has went up 57% in Kentucky over the previous year. More than that over 2018. 57%. That is just totally unacceptable. These are children dying, and I can't figure out why nobody's reporting that. We had 18% increase in near fatalities over that same time period, and overall with near fatalities, a 33% increase over 2019, and it's even higher than that percentage over 2018. So it just befuddles me why that is not newsworthy, to know that the things that are going on when all this other has taken the main stage and we're doing all these things. Well, what about our children? Their lives matter too. And we've had a 57% increase in loss of children because of these circumstances over the last year. Thank you.
Thank you, Representative. That's all the questions that I have. I'm going to give the panel an opportunity to close if they want to say anything. Not necessary, but if you want to, feel free to do so.
Thank you for that opportunity. I just want to clarify that we do not review all child fatalities. We only review those where there is an allegation of abuse or neglect. So we are only seeing a tiny portion of the overall fatalities that we see in children. And, I think that there is, a purpose for this panel. I think that we do good work. I think that we have done good work and have seen some successes. But I appreciate the committee's commitment to being helpful to us and to, helping us develop some teeth and some additional funding and staffing so that we can do even better work going forward. And I'll defer to my colleagues to see if they have anything to add.
Chris or Jeremy?
Representative Nemes, it's my job to make sure members are well informed, and there was some discussion about the National Center that I just want to make clear where our recommendations we're trying to get at there. We did not intend to recommend that the panel fully adopt and use the National Center's online web-based reporting system. We talked with the director of the National Center, and she was quite that whole center has been very helpful throughout this entire report. Said that they felt they could, their system could take any information Kentucky wanted to enter. Now, there's over 2,000 things there. It doesn't mean you have to enter in everything if they wanted to. Our point was that there are a lot of resources at that center. There are webinars. They have regional people working that will come to Kentucky and help them work through things. They have publications on best practices for making recommendations, best practices for findings. It just seemed like there were a lot of resources there that, as the panel continues to move forward in improving its data collections, how to make recommendations, improving their data tool, that those resources would be available. I just wanted to make clear to members that we weren't saying they should fully adopt the National Center's use of their data tool.
Thank you for that. I think that we're going to have a continuous conversation to be helpful to them.
Thank you.
And Dr. Salt, I think you have a comment. If so, close us down. Or if not, close us down anyway.
Yeah, so I want to thank you again for allowing us to present. And I think that I look forward to ongoing communication because it seems like we're on the same page of improving the issue of child maltreatment in Kentucky. So I look forward to ongoing work.
Sounds good. Now we're going to have to adopt this report. But before I do, one of the presenters mentioned the adult drug court or family drug court in Jefferson County, and it's the only one in the state. We need to expand it. It has been just private funded, and I want to call out some folks just in particular and thank them. This is the National Council of Jewish Women and Jane Emke. Also, our member of this committee, Joni Jenkins, has done a whole lot to help that group fund the program in Louisville. I've done a little bit. Joni's done a lot. Senator Julie Rocky Adams has done a lot, and so has Franklin Circuit Judge Phil Shepard. So I wanted to comment on those folks in helping us get the adult drug court in Jefferson County. Hopefully we can expand that. So I'll take a motion to adopt the report. Motion made by Representative Blanton, seconded by Senator Carroll. All in favor say aye. All opposed nay. The report is adopted, and we have no further business, so we are adjourned.